Good morning, everyone. I am thankful to Professor Bitul Gupta. It is amazing that how much a person can do. Those who are in his group will know that regularly he is actively so much active, and not only for academically but for the societal cause. My topic is perioperative and periprocedural management of antithrombotics. By antithrombotics, I mean anticoagulants and antiplatelet drugs. Many patients are on anticoagulants on long-term basis, like those who have atrial fibrillation, maybe with valvular heart disease or without valvular heart disease, or some patients who had DVT or pulmonary embolism in the recent past. They also put on anticoagulants for a longer period of time, and antiplatelet drugs for patients with CAD or post-ischemic stroke. And many of these patients, they do require some surgery or some biopsy or some procedure to be done, and because of surgery or procedure, there is risk of bleeding. So we will have to stop these anticoagulants, antiplatelet drugs for a brief period of time, and during that period, if there is thrombotic risk is high, we may have to give what we call bridge therapy. I will come to that later on. And the other situation is for short term, you start anticoagulants for 2 weeks or 3 weeks or 4 weeks, like those who have knee replacement or hip surgery. I will not be talking about this area. So these are common old anticoagulants, like vitamin K antagonist warfarin, which was the only anticoagulant available till recently. It is long half-life period. Antidote is protamine, and one important point is it is not excreted through kidney. Dabigatran, factor 2A inhibitor, very fast acting. One thing to remember is renal elimination is almost 80%. So we will have to be careful when we are prescribing the patients when their GFR is low. Rivaroxaban, apixaban, edoxaban, all of these are factor 10A inhibitors. XA is in their name, so all are 10A inhibitors. All are fast acting. Apixaban, renal elimination is only 25%. So maybe it is a good candidate for the patients who have CKD. Heparin, probably it is not very clear, is it? Anything can be done? Okay, I am sorry about that. So unfractionated heparin, low molecular weight heparin, and fondaparinux. Unfractionated heparin, action starts almost immediately. Route is IV or subcutaneously. Low molecular heparin, half-life is 20 to 30 minutes, route is only subcutaneous. Fondaparinux can be used when we cannot give heparin, like if the patient is heparin-induced thrombocytopenia. Route is subcutaneous and it is given once a day. Antiplatelet drugs and their duration of action. Aspirin, it is 4 days. P2Y12 inhibitors like clopidogrel, prasugrel, ticagrelor, or cangrelor. Clopidogrel is more potent than aspirin. Prasugrel and ticagrelor are more potent than clopidogrel. Cangrelor is given as infusion. Its action will last for 30 to 60 minutes after we have discontinued it. Abiciximab, again given as infusion. Its action lasts up to 48 hours after discontinuance of therapy. So when a surgery or procedure is required, we will have to assess what is the risk of bleeding. There is not much trials are available, but as per the International Society of Hemostasis and Thrombosis, it can be grouped into 3 categories: high risk of bleeding, low to moderate risk of bleeding, and minimal risk of bleeding. Minimal risk of bleeding, when the risk of major bleeding is 0%, low to moderate risk 0 to 2%, and high risk more than 2% risk of major bleeding. In the category of minimal risk of bleeding, procedures can be cataract, dental extraction, pacemaker implantation, cardioverter defibrillator implantation, minor skin procedures. Low to moderate risk, 0 to 2% risk of major bleeding, that is GI endoscopy or biopsy, bronchoscopy biopsy, lap cholecystectomy, epidural injection, abdominal hysterectomy, coronary angiography, abdominal hernia repair, pile surgery, skin or lymph node biopsy, arthroscopy, hand or foot surgery. The procedure that carries high risk of bleeding when the organ is highly vascular like liver, kidney or spleen, ERCP procedure, colonic polyp resection, cardiac surgery, intracranial surgery, spinal anesthesia, and any major operation lasting for more than 45 minutes. Bowel surgery, cancer surgery like solid tumor resection, major orthopedic surgery, plastic surgery, urologic surgery. This list is not exhaustive, but I have tried to cover the common procedures and surgeries. Then we have to assess what is risk of thrombosis. It depends on patient's profile. High risk of thromboembolism, if the patient had suppose recently DVT in the past in 3 months, or Chard's VAS score is very high, or the patient has atrial fibrillation with rheumatic heart disease, or the patient has received some mechanical valve, or the patient had TI recently, recent cardioembolic stroke, and active cancer who are at high risk of thromboembolism. LV thrombus diagnosed recently, severe thrombophilia, antiphospholipid antibodies. So the high risk of thrombosis, this category probably they will require what we call bridge therapy. Moderate risk of thromboembolism, if the patient had DVT in last 3 to 12 months or Chard's VAS score is 5 to 6. Low risk of thromboembolism, if the patient had DVT in the remote past or Chard's VAS score is 1 to 4. So this is as per a study, if the patient is not on anticoagulant, what is risk of stroke? If the Chard's VAS score is highest, that is 9, annual risk of stroke is 14.4%. When it is 2, risk of stroke is 2.5%. As the score increases, chances of stroke increases. So if the patient has received mechanical valve, so the risk of a stroke or arterial thromboembolism would depend on what is the type of valve, what is the position of the valve, and time since placement. Caged ball valve carries the highest risk. If the valve is placed in mitral position, is more riskier than aortic position. If the patient received the valve only recently, it carries the highest risk of thromboembolism. If the valve is placed in the remote past, carries a lower risk. So based on the pharmacokinetics of the anticoagulants, as I have told in the earlier slide, you will have to stop or interrupt this anticoagulant prior to surgery. So let us take an example of apixaban. If the surgical procedure carries a high risk of bleeding, then you stop it at least 2 days prior to surgery, and it can be restarted in 48 to 72 hours after surgery. If there is low to moderate risk of bleeding, you stop it for a day before surgery, and it can be resumed in 24 hours after surgery, provided hemostasis has been achieved and we are not planning any further surgical intervention. Same is the case with all the newer anticoagulants like dabigatran, edoxaban, rivaroxaban. But for dabigatran, because it is majority PET eliminated through kidney, so the GFR is less than 50. The interruption period is almost doubled. So that is in high risk of bleeding. You stop it for 4 days before the procedure, and when the risk of surgery is low to moderate risk of bleeding, you stop it for 2 days before surgery. So what is bridge therapy? During this period, because the risk of bleeding is there, we interrupt the anticoagulant or antiplatelet. And for this brief period, when the risk of thromboembolism is high, it is minimized by short-acting anticoagulants, and which has to be stopped hours before the procedure. So some studies which are available, this is published in NEJM way back in 2013. So pacemaker or defibrillator surgery without interruption of anticoagulation. As I told you, these are all low risk of major bleeding. So as compared with breech therapy with heparin, continued therapy with warfarin will carry the low risk of hematoma. That means you just continue warfarin, don't interrupt warfarin and give heparin. So breech therapy should be avoided in this situation. So this is systematic review published in the American Journal of Medicine. Patient had venous thromboembolism and were on this warfarin group of drugs, and it is seen that when you do not give breech therapy, also there is risk of bleeding is less and risk of thromboembolism is also less. So again, no breech therapy required if the patient had DVT or in the past and patient is on anticoagulants. And this is published in NEJM 2015, famous breech trial. Patients had atrial fibrillation and were taking vitamin K antagonists. So one group received no breech therapy, another group received breech therapy. So what it says that risk of thromboembolism is almost similar in both the groups, but the risk of major bleeding almost doubles or more than doubles if you give breech therapy. So again, as per this study, breech therapy is not required in majority of the cases. And this was published in JAMA Internal Medicine in 2019. Same as I told you earlier, same protocol was followed in this PAUSE trial, perioperative anticoagulant use in surgically evaluated patients. So same protocol was followed, and what they found is simple protocol of interruption of anticoagulants is enough, and there is no need to assess coagulation function. And in those cases, there is low rates of major bleeding and low risk of arterial thromboembolism. So, what to do with the patient is on warfarin or vitamin K antagonist? When there is minimal risk of bleeding, same therapeutic dose can be continued, but if there is low or moderate or high risk of bleeding, you stop it for 5 days before the surgery, and it can be restarted in 24 hours. But if there is thrombotic risk is high, then there is breech therapy with low molecular weight heparin. So that can be given 3 days before the surgery. That is, by this time the INR might have reduced to less than 2. So chance of thrombosis increases during that period. So the dose is therapeutic dose of 1 milligram of enoxaparin twice a day, and the last dose of this heparin is given 1 day prior in the morning. That means suppose you have planned surgery tomorrow, then last dose of low molecular heparin is given today morning. And post operatively, this breech therapy after 24 to 36 hours in case of low to moderate risk of bleeding. But if there is high risk of bleeding, you wait for 48 to 72 hours and start with half the dose, and after a day give full dose, and continue this heparin till 5 days. So by this time the warfarin will take over. So just to repeat, if the patient is on warfarin group of drugs, check INR 7 to 10 days before surgery. Stop 5 days before surgery when INR is 2 to 3. If bleeding risk is high, check INR on the day of surgery, and if INR is more than 1.5, give a small dose of vitamin K. Some authors say there is no need to check INR, you continue with the surgery. And if there is high risk of thrombosis, breech therapy is required. And post-operatively, resumption of warfarin in high bleeding risk category restart after 24 to 36 hours with the same dose. Low to moderate risk restart after 12 hours. And as I told you, continue breathing till INR 2 is achieved, that is about 5 days after the surgery. So that was of the anticoagulants. Now coming to antiplatelet drugs. Patient may be on single antiplatelet or double antiplatelet. If the patient is single antiplatelet and risk of bleeding is low, you can continue. But in the high risk of bleeding cases, temporarily interrupt and restart post-operatively once hemostasis has been achieved. But in those who have DAPT, that means the risk of thrombosis is high in those patients. So consider delaying elective surgery or consult a cardiologist. And in this situation, if surgery required, continue aspirin and stop clopidogrel group of drugs. So what are the situations with the patients may be on DAPT or double antiplatelet drugs? Acute coronary syndrome like ST elevation MI, non-ST elevation MI, unstable angina. In these patients, we give it for 12 months. If the patient had undergone percutaneous coronary intervention and stent placement. So in case of drug-eluting stent, it is given for 12 months. Post CABG after acute coronary syndrome, 12 months. Prevention of stroke, suppose the patient had TIA or minor stroke, we give DAPT for 3 weeks or 4 weeks. If the patient peripheral artery disease, if it is symptomatic, or patient undergo lower limb revascularization, so the patient may be on double antithrombotics, that is antiplatelet and maybe with rivaroxaban. So in these situations, when the patient is on 2 antiplatelet drugs, stop one, and it is usually clopidogrel or P2Y12 inhibitors that is interrupted. These are more potent than aspirin. And once you stop clopidogrel, there is chance of rebound platelet hyperactivity. That means chance of thrombosis increases. But if you are able to give aspirin during that period, chance of this thrombosis will be minimized. But if the bleeding risk is high, like brain surgery or spinal surgery, stop aspirin as well. It can be restarted after 24 to 48 hours if hemostasis has been achieved. So management of antiplatelet drugs during the procedure, if possible, continue aspirin throughout. Clopidogrel need to be stopped 5 days before surgery. Ticagrelor will have to stop it 3 to 5 days before surgery. And prasugrel need to be stopped for 7 to 10 days before surgery. And in this situation, the chance of thrombosis is high. We can give cangrelor, which is given as IV infusion. But there is not very low quality data is available on this drug, so it should not be routine practice. And post-operatively, clopidogrel group of drug can be restarted within 24 hours. So if the patient requires non-cardiac surgery, what is the period, optimal timing for elective or time-sensitive non-cardiac surgery for prior PCI requiring DAPT? If the patient had balloon angioplasty only, no stent was placed, delay it at least by 14 days. If the patient had received bare metal stent, which is rarely done nowadays, you stop it at least for 30 days. If the patient has received drug-eluting stent due to acute coronary syndrome, delay it for 12 months. If the patient received it for chronic coronary disease, delay it for 6 months. So if at all we do require surgery, so what is the anticoagulant reversal options? In all these situations, FFP is a good option, fresh frozen plasma. But many people do not advise because of the volume overload. But it is very easily available in most of blood bank. Other options we have is 4-factor prothrombin complex concentrate. It is contains factor 2, 5, 2, 7, 9, 10. And for warfarin, antidote is vitamin K. For apixaban, rivaroxaban, edoxaban, it is andexanet alpha. Andexanet alpha is factor 10 a decoy. That means this anticoagulant will bind to this andexanet so that factor 10A will be free for coagulation process. And for dabigatran, we have idarucizumab. So whenever in these situations, what to do? Consider what is risk of bleeding because of procedure itself, and what is risk of thrombosis because the patient's condition, the profile, and what is the patient's renal clearance. And the patient is on newer anticoagulants, we interrupt it only for a brief period. So probably bridge therapy is not recommended. But if the patient is on vitamin K antagonist, we interrupt it for nearly 5 days. So in that period, chance of thrombosis may increase because of the patient's profile. So in those cases, maybe we can consider bridge therapy. Thank you.